Welcome to the deep dive. Today's deep dive is it's custom tailored just for you because we know you're looking for that aha moment without having to wade through like a giant mountain of medical journals.
Right, we do the waiting for you.
Exactly.
Yeah.
And we have a really fascinating stack of sources in front of us today. We're looking at clinical rheology studies, cosmetic clinic literature, and some very stark warnings from the American College of Obstetricians and Gynecologists.
Yeah, it's a pretty wide range of perspectives.
It really is. And we are taking all of this information to answer one highly specific question, like why are non-animal stabilized hyaluronic acid gels, which are often called NASHA gels, clinically preferred over collagen or semi-permanent fillers for G-spot magnification?
I mean, it is a question that sounds incredibly niche at first glance, but to answer it, we really have to look at this wild intersection of tissue biomechanics, fluid dynamics, and risk management. We're going to objectively examine how all these different substances actually behave inside human tissue.
Yeah. And I want to be super clear up front. We are doing this strictly by the book. We're looking at the science and the mechanics here. We aren't here to take a side on the necessity of the procedure itself. We're just looking at the how and the why.
Right, just the underlying mechanics.
Okay, let's unpack this. Because usually when we discuss a medical intervention, there's, an expectation of precision. You break a bone, the doctor looks at an x-ray, points to a jagged line, and they fix it.
Yeah, it's standard protocol.
But when you look at the origins of this specific cosmetic procedure, like back in the early 2000s, it feels like the Wild West. I mean, we are talking about an intervention that started out as a highly guarded secret cocktail.
Which is an incredible starting point for a clinical discussion, honestly.
Right.
We are essentially tracking a massive paradigm shift here. We're moving from a completely opaque, almost mystical approach to cosmetic gynecology straight into a highly calculated manipulation of physics and anatomy.
Yeah, let's unpack that history first. So the concept we're looking at is often referred to in the clinic materials as the G-shot, or G-spot amplification. And it was pioneered by a Los Angeles cosmetic gynecologist named Dr. David Matlock.
Right, he was the primary architect of this.
And the clinical goal is very specific. The provider injects a dermal filler into the anterior vaginal wall to enlarge the G-spot to, well, the width of a quarter, and give it a projection, like a height of about a quarter of an inch.
Which is quite specific.
I want to pause on that for a second, because a quarter of an inch projection inside that specific anatomy, that seems structurally significant. What is the physiological rationale for doing that?
Well, the rationale outlined in the cosmetic literature is purely mechanical. By creating a larger, more prominent physical structure on the anterior vaginal wall, you naturally increase the surface area and the friction during intercourse.
Okay, that makes sense.
Yeah, and the theoretical outcome of that increased friction is heightened sexual gratification.
Right. And I say theoretical because in those early days, Dr. Matlock wasn't exactly publishing his formula in peer-reviewed journals. Like, our sources note that he originally used a secret formulated substance with an active ingredient of collagen.
Yes.
He actually likened it to the closely guarded Coca-Cola recipe.
Which, what's fascinating here is, from a modern medical perspective, injecting an undisclosed proprietary mixture into a highly vascular, densely innervated mucosal area, that raised a lot of questions.
I'd imagine so.
Yeah, because transparency is usually the absolute bedrock of clinical safety.
And the broader medical community certainly had questions about it. Which brings us to the American College of Obstetricians and Gynecologists, or ACOG. Their committee opinion on this procedure is severe. They state unequivocally that this procedure is not medically indicated.
They do, yeah. ACOG highlights a severe lack of high-quality efficacy data. But more importantly, they lay out a very specific profile of risks. They list infection, bleeding, altered sensation, and dyspareunia, which is the clinical term for painful intercourse.
And the literature also mentions a much more terrifying systemic risk, something called a fatal non-thrombotic pulmonary embolism. I mean, I understand what an embolism is broadly, but how does injecting a filler into the vaginal wall potentially damage the lungs?
Right, that is a crucial mechanical question. So the anterior vaginal wall is heavily vascularized, meaning it is packed with this dense network of blood vessels.
Okay.
If a provider accidentally injects the filler directly into one of those vessels, an intravascular injection, the material doesn't just sit there.
It travels.
Exactly. It enters the venous system, it travels back up through the body, passes right through the right side of the heart, and is pumped directly into the lungs.
Oh, wow. So it just physically blocks the blood vessels in the lungs.
Exactly. And the term non-thrombotic simply means the blockage isn't caused by a blood clot, like a typical embolism. It's caused by the filler material itself.
Right.
It blocks an artery in the lungs, preventing oxygenation, which obviously can be catastrophic.
Okay, so if ACOG is sounding the alarm on these massive risks, but the cosmetic clinic data shows patients are, still actively demanding and paying for the procedure, the pressure is entirely on the industry to find a safer material, right?
Yes, absolutely.
So what were they using before we had modern fillers?
Well, historically, the industry relied heavily on bovine collagen, derived from cows. The most well-known brand at the time was called Zyplast.
Bovine collagen, so it's from a cow. I'm assuming the fact that it comes from a cow presents some immediate compatibility issues with the human immune system.
Oh, a major issue. Because it is an animal protein, the human body instantly recognizes it as foreign, so it carried a significant risk of allergic reaction.
Oh, wow.
Patients actually had to undergo pre-injection allergy skin testing. They would get this small test dose in their arm and then wait weeks, literally weeks, to see if they mounted an immune response before they could even schedule the actual procedure.
That sounds incredibly tedious for an elective procedure. But even if they, pass the allergy test, the sources say the results were notoriously short-lived. Why did it fade so fast?
Because the body's macrophages, those are the cells that basically act as garbage collectors, cleaning up cellular debris. They're very efficient at breaking down and clearing out foreign animal proteins.
Ah, so they just eat it up.
Right, the enzymatic degradation happens rapidly. You might only get 2 to 3 months of structural projection before the collagen is completely absorbed.
Okay, I want to look at this from the patient's perspective for a second.
Yeah.
If I am paying thousands of dollars to augment a specific anatomical structure, I really don't want something that washes away in 12 weeks.
Naturally.
Like, to use a construction analogy, if I'm building a house, I want to pour concrete for the foundation. I don't want to sculpt it out of wet clay that's going to dissolve in the rain. So why wouldn't aesthetic medicine just use permanent fillers?
Well, aesthetic medicine did explore that route, actually. The sources detail a major shift toward non-hyaluronic acid fillers, which are often called semi-permanent or permanent fillers.
Let's slow down and define those because the acronym soup in the literature gets pretty thick right here.
It really does.
The sources mention PMMA, which is sold under the brand name Belafil. They mention calcium hydroxylapatite, or Ka, and polylactic acid, which is PLLA. What do these actually do inside the body?
Your concrete analogy is actually perfect for explaining this. These fillers are typically composed of tiny microscopic spheres suspended in a carrier gel.
Okay.
When injected, the carrier gel is absorbed by the body over a few months, but those tiny solid spheres remain behind in the tissue. They act as a permanent scaffold.
A permanent scaffold, but what is building on it?
Your body's own immune system.
Oh.
Yeah, the body detects these microspheres and realizes it can't break them down like it did the bovine collagen. So it mounts a mild, localized inflammatory response.
Okay, so it gets inflamed.
Right, and this inflammation triggers cells called fibroblasts to rush to the area and produce your own natural collagen, basically wrapping around the spheres to wall them off.
That process, it sounds a lot like how the body forms a scar.
That is exactly what it is. The clinical term is fibrosis. It is essentially controlled scar tissue designed to create permanent volume.
Wait, controlled scar tissue? In a highly innervated mucosal wall?
Yeah.
That sounds like a massive liability.
It is the severe downside of the concrete approach, because it is entirely irreversible. Let's look back at the ACOG warnings regarding altered sensation and dyspareunia.
Right.
If you inject a permanent filler into a highly sensitive area and the body overreacts, the results are devastating.
What does an overreaction look like in this specific context?
Well, the body might form painful, palpable nodules, or the tissue might undergo calcification, where it literally becomes hard and rigid.
Oh, wow.
And if that happens with a permanent filler like PMMA or Sehe, there is no chemical way to dissolve it. The only way to remove that concrete from the tissue is through invasive surgical excision.
You mean they have to cut it out?
Yeah, the surgeon literally has to cut the scar tissue and the microspheres out of the vaginal wall.
I see. So the risk profile is just entirely disproportionate. If you make a mistake, or even if the patient's immune system just reacts aggressively, they're stuck with painful scar tissue in an incredibly sensitive area. And the only fix is going under the knife.
Precisely. For an elective cosmetic enhancement, that level of risk management is completely untenable.
which perfectly sets the stage for what the sources call the modern safety net, hyaluronic acid, or HA. The literature shows HA has almost entirely taken over this specific market. But what is HA, biologically speaking?
Hyaluronic acid is a glycosaminoglycan.
Okay, big word.
Right. Simply put, it's a long chain of sugar molecules that naturally occurs in the human body. You find it everywhere, in your connective tissue, your skin, the synovial fluid in your joints, and even your eyes.
I mean, I know it's super popular in skincare serums right now. Its main claim to fame is hydration, right? It draws in moisture.
Exactly. It is incredibly hydrophilic. A single gram of hyaluronic acid can hold up to 1,000 times its weight in water.
Wow, 1,000 times.
Yeah, it volumizes the tissue by acting like a microscopic sponge, pulling in surrounding fluid.
Okay, so it draws in water like a sponge. That explains how you get the volume for the procedure. But if the goal of the industry was to avoid the permanent nightmares of PMMA and scar tissue, how does a water sponge solve the permanence issue?
It solves it through an enzyme called hyaluronidase. This is the critical differentiator. HA fillers are 100% reversible.
Reversible, how does that work mechanically?
Well, if a patient experiences a complication, say painful nodule forms, or critically, if the filler accidentally compresses a blood vessel and restricts blood flow, the provider can immediately inject hyaluronidase into the area.
What does that do?
This enzyme acts like a pair of molecular scissors. It rapidly cleaves the bonds of the hyaluronic acid polymer chain, breaking it down into harmless liquid byproducts. The body's lymphatic system then flushes those byproducts away within a matter of hours.
That's incredible. It's basically a magic eraser.
Exactly. It completely dissolves the filler. So if we connect this back to ACOG's stark warnings about painful intercourse and vascular risks, having that reversibility isn't just like a convenient feature.
No, it's essential.
It is an absolute clinical necessity. It mitigates the nightmare scenario of permanent surgical excision entirely.
That makes complete sense. But I'm looking at the rheology sections of these clinical studies, and the science doesn't stop at just choosing HA. The sources are absolutely adamant that you cannot just take any hyaluronic acid filler off the shelf and use it for G-spot amplification.
No, you absolutely cannot. The anterior vaginal wall is a dynamic, high-pressure, high-friction environment.
Right.
If you inject a soft, liquidy, highly spreadable HA gel into that space, the sheer physical pressure of the surrounding tissue is just going to flatten it out. It will completely dissipate and fail to hold a shape.
Here's where it gets really interesting, so I want to dig into the physics here.
Mm.
The sources get very specific. They compare two major technologies, OBT, which stands for Optimal Balance Technology, and NASHA, which is non-animal stabilized hyaluronic acid.
Right, the two big players.
And for this specific anatomical target, NASHA is vastly preferred. Why is that?
It all comes down to a concept in fluid dynamics and rheology called G prime, which is also known as the elastic modulus.
Let's define that for the listener. What is G prime actually measuring?
G prime measures a gel's firmness and its ability to resist deformation when pressure is applied.
Okay.
A high G prime means the gel is firm, it's highly structural, and it will spring back to its original shape under stress. A low G prime means the gel is soft, flexible, and deforms or spreads out easily.
The numbers in the studies are pretty striking when you look at the gap between the two.
They really are. The clinical studies show that OBT gels like Restylane Refine or Define have a G prime ranging from about 70 to 271 Pascal.
Okay, 70 to 271.
But if you look at a NASHA gel, like Restylane Lift, the G prime jumps up to 799 pascals. It is exponentially firmer.
Wow. What is happening at the manufacturing level to create that massive difference in firmness?
It is the difference between creating a monophasic gel and a biphasic gel. OBT gels are monophasic. During manufacturing, the HA chains are cross-linked into the smooth, continuous, highly cohesive mixture.
Smooth and cohesive.
Yes, they stretch and move easily with the tissue. That makes them excellent for areas of the face with a lot of expression, like the lips or around the mouth, where you want the filler to move naturally when you smile.
But NASHA gels are biphasic. The studies also refer to them as particulate gels. What does that actually mean? Like, it's not a smooth mixture.
Correct. It's not smooth at all. After the hyaluronic acid chains are cross-linked into a solid block, the manufacturer pushes that block through a microscopic sieve. This process creates tiny, solid pearls of gel. We are talking about particles roughly 250 micrometers in diameter. In every single milliliter of a NASHA filler, There are about 100,000 of these solid pearls suspended in a tiny amount of uncross-linked fluid.
Wait, 100,000 pearls in 1 single milliliter.
Yes, in just 1 milliliter.
I want to try an analogy here to help visualize cohesivity and lift, because, the physics can get pretty dense. An OBT gel, the smooth monophasic one, sounds like honey. It is thick, it is cohesive, meaning it sticks to itself. But if you put a dollop of honey on a table and press your hand down on it, it immediately spreads out flat.
That is a very accurate way to visualize high cohesivity and low G prime. It flows.
But a NASHA gel, because it's made of 100,000 tiny pearls, is more like a pile of wet gravel. The gravel has very low cohesivity, like the rocks don't stick to each other like honey does.
Right.
But if you stackpile wet gravel, it stays exactly where you put it. You press down on the pile, and the rocks push back against your hand. They resist deformation.
That resistance is the high G prime at work. Because the particles don't stick together and flow, the gel stays as a targeted, localized, firm bolus. And this mechanical property is the entire crux of why this deep dive exists.
Because to achieve the procedure Dr. Matlock outlined, the provider needs to build a precise, quarter-sized, three-dimensional structure that projects a quarter of an inch out from the vaginal wall.
And critically, it has to maintain that three-dimensional structural projection while withstanding significant repeated physical friction.
Can't just scoosh away.
Exactly. It cannot migrate into the surrounding tissue. You need the mechanical, skeletal-like support that only the solid pearls of a NASHA gel can provide. If a provider used a soft OBT gel like the honey, it would just flatten out and disappear into the mucosal tissue under pressure.
So, tracing the entire journey of this procedure, it is quite a leap. I mean, it started in the early 2000s as this mysterious proprietary collagen cocktail that was unpredictable, faded quickly, and carried significant allergy risks.
And as patient demand grew, the science had to adapt rapidly to mitigate those inherent dangers. The aesthetic industry learned very quickly that permanent fillers were a massive liability because they caused irreversible fibrosis in highly sensitive tissue.
So the shift to hyaluronic acid became absolutely mandatory.
Completely mandatory.
Because HA provides that essential safety net.
Mm-hmm.
The magic eraser of the hyaluronidase enzyme means that if a complication arises, the provider can instantly cleave the bonds of the filler and flush it out of the body, avoiding surgical excision entirely.
But safety was really only half the equation. It had to actually work mechanically under high stress, and that is where the precise rheology of NASHA technology became the gold standard for this specific anatomy.
Right.
The high G prime and the particulate biphasic structure provide the exact, immovable 3D lift required to achieve the physical augmentation.
So what does this all mean? We really have gone from a secret recipe to a marvel of calculated biomechanical engineering. Though, as we wrap up, we do need to impartially remind you, the listener, that while the physics and fluid dynamics of these modern fillers are undeniably fascinating, the medical necessity of the procedure itself remains highly contested.
That's right.
Governing bodies like ACOG still point to the lack of efficacy data and the baseline risks of injecting anything into that anatomy.
It is a vital clinical distinction to keep in mind. The engineering of the material itself is brilliant, but the application is heavily debated. And frankly, understanding how precise this engineering has become raises a much larger, somewhat provocative question about the future of medicine.
Oh, I am intrigued. What is the question?
Well, think about the level of molecular control we just discussed. Aesthetic medicine can now manipulate the elastic modulus and calibrate the exact micrometer size of a particle to perfectly mimic, or in this case amplify, a highly specific, localized human nerve center.
Right. We aren't just filling in a wrinkle on a forehead anymore.
Exactly. We are structurally hacking the body's mechanics. So the question is, if material science allows us to engineer gels that can structurally hack a specific sensory function in mucosal tissue, what other physiological or sensory functions in the human body might be structurally manipulated or amplified next?
Wow. That is a wild thought to mull over. From smoothing out a smile line to literally engineering physical sensation through the manipulation of fluid dynamics. Thank you for joining us on this deep dive. It is the perfect reminder to look past the marketing brochures, dig into the mechanics, and always keep questioning the science behind the headlines. Until next time.